Hello and welcome to the topic Aortic Regurgitation in the Cardiology module. By the end of this topic, you should be able to define aortic regurgitation, explain the causes and pathophysiology of aortic regurgitation, classify aortic regurgitation, describe the clinical features of aortic regurgitation, and outline the principles of management of aortic regurgitation. Let's get started. So what is aortic regurgitation? Aortic regurgitation, or also known as aortic valve insufficiency, describes the incomplete closure of the aortic valve with pathological reflux of blood back to the left ventricle during diastole, and this is what we call regurgitation. What are the causes of aortic regurgitation? Now, this can be classified into congenital and acquired forms of aortic regurgitation. It can be seen as part of a congenital condition as seen in Marfan syndrome or Ehlers-Danlos syndrome. It can also be present as a congenital bicuspid aortic valve, which leads to regurgitation. Acquired forms of this condition can arise from infections such as bacterial endocarditis and syphilis, which affects the aortic root and valve itself, ankylosing spondylitis, aortic dissection, hypertension, and post-procedures such as seen in transcatheter aortic valve replacement or left ventricular assisted device placement. The severity of aortic insufficiency or regurgitation can be classified according to the degree of diastolic reflux, which is known as the regurgitation fraction. This can be evaluated as part of cardiac catheterization with the introduction of a contrast medium into the ascending aorta. Level 1 indicates regurgitation fraction of less than 20%. There's very little contrast medium that enters the left ventricle and it's completely excreted during systole. Level 2, whereby we have regurgitation fraction between 20 to 39%. The left ventricle fills up completely but is weak after several heartbeats with the contrast medium. Level 3 is regurgitation fraction 40 to 60%. The left ventricle fills up completely with the contrast medium. The contrast medium density in the left ventricle corresponds to the density in the ascending aorta. And finally, level 4, where we have the regurgitation fraction more than 60%. The left ventricle fills up completely with the contrast agent during the first heartbeat. The contrast agent density is higher in the left ventricle than in the ascending aorta. Now let's take a look at the pathophysiology of aortic regurgitation. Due to the constant backflow of blood into the left ventricle, the volume load rises. Therefore, a chronic aortic valve insufficiency causes an isolated left ventricular hypertrophy. Initially, the cardiac output can be maintained and the patient remains asymptomatic. With persistent insufficiency, however, the compliance of the ventricle decreases so that normal stroke volume can no longer be maintained. The perfusion of the left ventricle with oxygen cannot sufficiently occur. Peripheral resistance increases and the duration of the diastole is extended. This change can increase the magnitude of the insufficiency. Now, let's look at the clinical features of aortic regurgitation. Acute aortic valve insufficiency leads to a rapid left cardiac decompensation with pulmonary edema. Chronic insufficiency can be tolerated for decades and remain asymptomatic. The first signs are usually palpitations. With the progression of the disease, reduced performance and signs of left ventricular failure becoming apparent. Syncope, dyspnea, or arrhythmia, as well as angina pectoris and sudden death, can be symptoms, but compared to aortic stenosis, this occurs only rarely. Examination-wise, look for murmurs due to aortic insufficiency. The diastolic decrescendo murmur is best heard at the left third intercostal space, second aortic area. Early diastolic murmur is heard and the intensity of the murmur is increased by the hand grip maneuver. Valsalva and standing decreases the preload and decreases the intensity of the murmur. A mid-diastolic Austin Flint murmur is present in severe aortic regurgitation, and this is due to the partial closure of the anterior mitral valve cusp caused by the regurgitation streams. Additionally, low diastolic blood pressure with a high pulse amplitude and water hammer pulse, or also known as collapsing pulse, as well as Demusset's sign, where you have the head bobbing, and the Muller's sign can be found in cases of severe insufficiencies. Rapid raising carotid pulse with sudden collapse can also be seen. Another sign that is also found in aortic regurgitation would be a wide pulse pressure. And lastly, Quincke's sign, where you're able to look at the nail bed pulsation. The best modality to diagnose aortic regurgitation is with the use of echocardiogram. It helps with assessing the severity of the valve defect. It helps with quantifying the left ventricular size and function, measures the annular size and the root of aorta. ECG may show changes that have occurred as a consequence of the valve defect, and these include left ventricular hypertrophy, left axis deviation, left atrial enlargement, left volume overload pattern, and left ventricular conduction defects. Now, let's take a look at the treatment of aortic regurgitation, which can be broadly categorized as medical therapy and surgical therapy. So, vasodilators are used to decrease afterload. Examples include ACE inhibitors and ARBs. To reduce pulmonary congestion, we can use diuretics or digitalis. Aortic valve insufficiency can be treated conservatively if patients are generally asymptomatic. Patients who have hemodynamic insufficiency can exercise regularly but should avoid excessive efforts. Surgical intervention is indicated if patients are symptomatic or asymptomatic patients which show an ejection fraction less than 50% or a left ventricle end diastolic diameter of more than 70 millimeters, alternatively an end systolic diameter of more than 50 millimeters. Now this slide shows a quick note on abnormal heart sounds. Loud S2 is heard in hypertension, hyperdynamic states, and atrial septal defect without pulmonary hypertension. Soft second heart sound is heard in aortic stenosis. A fixed split second heart sound is heard in atrial septal defect. A widely split second heart sound is found in deep inspiration, right bundle branch block, pulmonary stenosis, and severe mitral regurgitation. And finally, a reversed or paradoxical split of the second heart sound, whereby P2 occurs before A2, happens in left bundle branch block, severe aortic stenosis, right ventricular pacing, WPW type B, and patent ductus arteriosus, and is always pathological. Let's summarize. Aortic regurgitation is a cardiac condition characterized by the backflow of blood from the aorta to the left ventricle during diastole. Aortic regurgitation is associated with an abnormal aortic valve and or aortic root stemming from multiple causes, commonly rheumatic heart disease, as well as congenital and degenerative valvular disorders. Thus, echocardiogram shows left ventricular hypertrophy and dilation along with valvular abnormalities. Eventually, congestive heart failure occurs as the left ventricle is unable to handle the hemodynamic overload. Aortic valve replacement is the mainstay of treatment for AR with left ventricular dysfunction. Now we have come to the end of this topic. Thank you.